Good morning, and I welcome everybody globally for a webinar on To Sleep, Perchance to Dream. And we have two excellent speakers today to discuss this extremely important topic. This is the first webinar of 2023, so Happy New Year to everybody. My name is Wendy Wolfman, and I'm a professor in the Department of Obstetrics and Gynecology at the University of Toronto, Canada. I'm also director of the Menopause and Premature Ovarian Insufficiency Clinic and a board member of the International Menopause Society. So the plans today are to introduce our first speaker, Professor Hadeen Joffe, and then she will give her talk. And then I will introduce Professor Tommaso Sommaccini. And at the end of their presentations, we will entertain questions which are given on the Q&A button. Please put them in as we go along. So this presentation is being sponsored with an unrestricted grant from Bessin. And Bessin Healthcare had no role in the selection of topics, selection of speakers, and have not vetted or reviewed the content of the speakers' presentations. Remember about our international meeting coming up in 2024 in October. So the first speaker is Professor Joffe. She is Executive Director of the Mary Horrigan Connors Center for Women's Health and Gender Biology. She's Executive Vice Chair for Academic and Faculty Affairs, Department of Psychiatry, Brigham and Women's Hospital, and the Paula A. Johnson Professor of Psychiatry in the field of women's health at Harvard Medical School. She's an experienced clinician and clinical reproductive neuroscientist in the field of women's brain health in relation to midlife aging, mental health, and neurobehavioral consequences of cancer therapies. Gives me great pleasure to introduce Dr. Joffe, who I know has a particular interest and expertise in sleep, and in particular with menopause and its effects. Thank you, Dr. Joffe.
Thank you, Dr. Wolfman, and to the organizers for inviting me to speak on my favorite topic, menopause and sleep. So my disclosures are here. I'm presenting work from my NIH grants. So I have three parts to this presentation. I first want to describe the multidimensional components of sleep and then insomnia syndrome. I then want to specify what we know about sleep disturbance in relation to menopause and hot flashes with implications for treatment that Dr. Sommaccini will continue in the second part of the presentation. And I also want to highlight some critical work about how important menopause-associated sleep disturbance is for our well-being overall, both neuropsychological well-being and cardiometabolic well-being. So perhaps you all know this, but I want to make sure we put a point on what insomnia disorder is. It is not what we call colloquially insomnia or sleep problem. It is a clinical condition. It's in America, the DSM. The key diagnostic criteria here, but the main points are that it's persistent and pervasive, lasting 3 months. It occurs at least 3 nights a week, and it can be a combination of sleep problems, beginning, middle, or end of the night. And it, by definition, is associated with daytime dysfunction. So it interferes with function. It affects about 10% of the population chronically, with another 10 to 15% intermittently. And it's much more common in women and also increases as people age, which means that as people enter the perimenopause and early postmenopause, you have this aging effect of risk for insomnia in addition to menopause-related sleep disturbance. And it can be very tricky. So to contrast what sleep disturbance is, it is not insomnia. It's a subthreshold condition. It's less pervasive. And it can have many different components. It might be merely a sleep onset problem. It might be sleeping at the wrong time of day, but getting sufficient hours of sleep. It might be, as you'll hear, specifically for menopause and hot flashes, what we call a WASO problem, wake after sleep onset, a sleep maintenance problem, where sleep is interrupted or fragmented multiple times in the middle of the night. But it doesn't necessarily have the same daytime impact in terms of dysfunction. That's not to say that it doesn't affect people's well-being, but it is less severe. And there's been really great work by Dan Bicey and others to look at these multidimensional components, the sort of global idea that, you know, sleep is a combination of factors. It's not one entity. It means, are you satisfied? He has a SATED questionnaire. Are you alert during the day? Are you sleeping at around the right time of day? Do you spend most of your time in bed asleep, and do you get sufficient number of hours? So this is a useful construct. Are you sated to appreciate people's sleep disturbance? So what about menopause and hot flashes and sleep disturbance? I know people know a lot about hot flashes here, but just to remind everyone that the median duration of hot flashes is 7 to 9 years. And this is during the perimenopause and into the postmenopause. So that even by the age of 60, a significant proportion of women, about a third, will continue to have vasomotor symptoms. So as a major contributor to sleep disturbance, vasomotor symptoms continue across many years and are likely to contribute across midlife. There are many vasomotor or hot flash symptom therapies. The goal in this talk is not to address them, but the main point to say is that treatments that are effective for hot flashes are, for the most part, effective for the sleep disturbance that is related to the hot flashes. So to the extent that they are co-occurring and the hot flashes account for the vast majority or a lot of the sleep problem, you can expect that treating hot flashes will also treat the sleep disturbance. And we had an NIH-funded multi-center clinical trial network that investigated a number of therapies over the years. And I'll give you one summary slide of our hot flash therapies for the treatments we use. This is over weeks on the x-axis here, up to 12 weeks, and everybody's starting at baseline hot flashes, so going down is improvement. And what you can see is that we had the biggest improvement from estradiol, then the serotonin agents, whereas we did not see effects from these behavioral interventions. Now, when it comes to menopause and sleep disturbance and hot flashes, it's not as simple as we would like it to be. It never is. Of course, hot flashes, as you will hear in the rest of my talk, are the major contributor. But there are other important contributors as well that I've listed here, you know, stress and environmental factors, a primary insomnia disorder that predated the menopause transition and persists, restless leg syndrome or periodic leg movements, which are linked, depression and sleep apnea. And before we get into the rest of the talk on hot flashes, I want to highlight just briefly how important it is to not overlook depression and sleep apnea. Let me come back to that in 1 second. Depression risk is doubled to quadrupled as women cross the perimenopause. So it's a significant period of vulnerability, and there are notable sleep disturbances as part of depression. And similarly, obstructive sleep apnea, which people think is a man's disease, becomes more of a problem for women. There's a doubling to tripling of risk for mild and even severe sleep apnea as women progress into the perimenopause and early postmenopause. So we should not overlook the possibility that other serious and important conditions might be contributing to the sleep disturbance. And I'll just draw your attention to the bottom right of the slide here, which is that we recently showed that in the absence of hot flashes, in a perimenopausal population, just the hypoestrogenism itself contributes to sleep interruption. So this indicates that it's not just the hot flashes, but also the changes in estrogen that contribute to menopausal sleep disturbance. And of course, all of these things can co-occur, and they often do. And that makes managing sleep disturbance complicated because you need to identify what the key triggers and contributors are and intervene appropriately. So what do we know about sleep disturbance across the perimenopause? You can see in this slide from some of our SWAN data that across the years from the final menstrual period, there's a significant increase on the y-axis of women reporting any sleep problem. And the main problem that is reported is this waking up repeatedly in the middle of the night, whereas you see much less of an effect of early morning awakening and sleep onset or falling asleep problem. And when you look more specifically in the waking up several times a night problem, what you see is that 15% of women will have this onset of sleep problems, waking up repeatedly across the final menstrual period years. And another 18% are persistently bad sleepers. So altogether, about a third of women are likely to have notable problems with sleep maintenance or sleep interruption in the middle of the night. Some of the work that I do in my sleep lab is we do EEG recording. This is a Google image here where we look at EOG, EEG, and EMG to do objective recording of sleep. And we do this in experimental models where we actually medically induce menopause, you can see in the top left, because we take advantage of the known outcome from a GnRH agonist, leuprolide, that some women and men get hot flashes and some do not. And then we can look at this with in-person change and what happens on the polysomnogram, looking at a typical hypnogram on the bottom left. What happens? What are the new onset changes that occur in the EEG when hot flashes emerge? And what you can see is what we know clinically. We objectively documented this, that as people move, as for those who have frequent hot flashes in the dark pink here, they have more new awakenings after developing hot flashes and more number of minutes awake after sleep onset when they develop hot flashes, whereas those who were on the GnRH agonist but did not develop hot flashes in the blue really had negligible change in any of their sleep parameters. And so you see this shifting towards more wakefulness, number of minutes awake in the middle of the night, and also a shift towards N1 sleep, which is light sleep. So we know that hot flashes at night or vasomotor symptoms occur mostly during wake or during light sleep. We know that the vast majority are associated with a wake episode, although not all. And we also know that they account for a large percentage of the wake time after sleep onset. Here's something we learned, and others, Fiona Baker's group also demonstrated, that when women have hot flashes, there's much more wakefulness independent of the hot flash events. So meaning if somebody has 2 hot flashes in the middle of the night, you can bet that she's having a lot more sleep disruption even when she's not having the hot flash events. So there's this fragmentation, this interruption, poor sleep quality throughout the night. And we do these studies where we measure vasomotor symptoms objectively so that we don't, we can rely on an objective indicator of hot flashes in the middle of the night. So it's we know that there's an uncoupling of the individual hot flashes from individual wakes. Yes, when people have hot flashes, they mostly wake, but even when they're not flashing, they're having poor quality, unrefreshing sleep. And that's why they're presenting, of course, for care. So again, going back to these MS Flash trials and the summary, when we looked at the subset of women, these are women coming in for hot flash therapy trials. The vast majority of them have a significant sleep problem. And we looked at the analyses we did in terms of the specific interventions we use in a series of trials. What you can see is improvement in insomnia symptoms or sleep symptoms on the y-axis, You can see that cognitive behavioral therapy for insomnia is most effective. Exercise was effective, even though it did not improve hot flashes. And then other benefits were seen from the SSRI in the orange, in the purple, the SNRI, and from estradiol. And in general, estradiol has less of an effect, less of a benefit than the SSRIs do in these studies. So now, one important point I want to make is that when we see sleep disturbance in relation to hot flashes or menopause, it's not a shortening of the number of hours of sleep. We think of sleep in terms of hours of sleep often. And that's not the case in the perimenopause, postmenopause. You actually see this lengthening of the number of hours of sleep. And some people have thought, oh, is that an improvement? But actually, we think that it's more a compensatory strategy, meaning people have poor quality sleep, and so they try to achieve more sleep benefit by having more time in bed. But the quality of the sleep in those additional hours and minutes in bed is still poor quality. So it's an attempt to achieve more sleep, but it's all poor quality sleep, unfortunately, when you have hot flashes. So why is this relevant for our public health? So at least in the US, the focus we have is on getting enough sleep. Are you getting enough hours of sleep? And there's really not been much attention paid to whether people are getting good quality sleep or uninterrupted sleep or continuous sleep. And we know short sleep time, fewer hours of sleep, is adversely related to mood, well-being, also cardiometabolic disruption. And we've wondered in some of our research to the extent that this translates to a hot flash sleep problem where you don't have the short sleep time. What you have is this sleep interruption and fragmentation in the setting of a preserved sufficient number of total sleep hours. The question we've been asking in some recent studies is, when it's interrupted sleep but sufficient hours, do you get these adverse mood, neuropsychological symptoms, and metabolic dysregulation? And I will argue that this actually, although we think of it as a menopause and hot flash problem, women's sleep problems tend to be a sleep interruption problem across different reproductive stages. And there's been a lot of interest in looking at cardiometabolic changes with menopause. What are the changes that contribute to the weight gain and body fat gain? To what extent might sleep contribute? This has been something that for many years has been attributed to the estrogen changes, the estrogen withdrawal. And we see so much obesity and body fat gain across midlife and beyond. That the question was, is it all the estradiol withdrawal? And if you look at these two figures, which I've lined up here, in the bottom is the perimenopause, where the estradiol is still intermittently created. And in the top, you see the accumulation of body fat. So there's an accumulation of body fat that is occurring when there's still significant estradiol production and intermittent ovulation. And so one of the questions is, maybe it's not all the estradiol withdrawal. Maybe some of the adverse adiposity might also be attributed to the sleep interruption, which in and of itself is modifiable and could be a therapeutic target. And so we've done more experimental studies where we, here just briefly the design, we again take healthy premenopausal women and give them a GnRH agonist to suppress their estrogen for several weeks. And we study them first in the sleep block when their estradiol is high in the mid-late follicular phase, and again when they're hypoestrogenic. We added another complexity here where we give them an A and C. We let them sleep in the sleep lab under EEG monitoring. And B and D, we wake them up repeatedly throughout the night with an acoustic stimulus to mimic sort of a severe hot flash related sleep interruption scenario. So this model enables us to distinguish the sleep interruption from the estradiol withdrawal. If you can imagine contrasting A and B, both they're estrogenized, but one has significant sleep interruption and one doesn't. And the CD contrast is the same, except in the hypoestrogenic and so forth. And in this study, we've been able to look at, I'll briefly mention some of our neurocognitive outcomes and also some of the metabolic outcomes that we measured. So just very briefly, we look at affect. This is what somebody's emotional state is in the morning. And what we've been able to show is both worsening of negative affect and worsening of positive affect when sleep is interrupted. Whereas in contrast, the estradiol withdrawal does not dysregulate affect. And what this says is that sleep interruption itself is a modifiable target for affective state, whereas focusing on estradiol withdrawal didn't contribute. In terms of some of the metabolic outcomes, just very briefly, we looked at, this is nutrient utilization, which is in the setting of the same diet. We control their diet. We give them a specific amount of food. They have to eat a specific amount. In that setting, what nutrients does their body tend to use? And if the nutrient pattern means more carbohydrate utilization, that is a propensity towards weight gain. We measure this in the lab with something called an indirect calorimetry at rest here. And I won't get into the details here, but essentially we were able to show that with both estradiol withdrawal and with the sleep fragmentation, there's a shift towards carbohydrate nutrient utilization, which increases the propensity towards weight gain. So both the hypoestrogenism and the sleep interruption are important contributors to a body fat or weight gain propensity. So how do I put these things together in terms of the implications for health overall? I will say that this sleep interruption pattern of hot flashes and menopause contributes to daytime mood and well-being and adverse metabolism. So this is important even when the sufficient number of hours is achieved. So we don't want to only focus people in a public health message on getting sufficient sleep hours. We want to make sure that they get continuous sleep to the extent possible. We want to make sure that they prioritize their WASO, meaning we don't want them waking up repeatedly in the middle of the night. And for many women, that means treating their hot flashes and of course other factors as well. So this is some of my team here, my research group who've done this work with me, and just to thank my funders and also the many wonderful interdisciplinary collaborators and research staff and volunteers. Thank you very much.
Thank you so much, Dr. Joffe. And you really provided some really fascinating new information. The next speaker is Professor Simoncini. He's a professor in the Department of Obstetrics and Gynecology at the Department of Clinical and Experimental Medicine of the University of Pisa and head of the OBGYN division. He is the scientific director of the Molecular and Cellular Gynecological Endocrinology Laboratory. He also performs clinical research, particularly on the effect of steroidal drugs on endometriosis, on the role of the fetal placental nitric oxide system in fetal growth restriction or on preterm birth. As well, he does surgical techniques in pelvic floor diseases, on computer-assisted pre-surgical simulation, and on innovative robotic surgical approaches to benign and malignant gynecological diseases. It gives me great pleasure to present Professor Simoncini, and we're looking forward to his talk. Remember to present your question and answers in the boxes, and we will answer them at the end. Thank you.
Thank you so much, Professor Wolfman, for introducing me. I hope my slides are regularly on show. And I'd like to thank also Professor Joffe for introducing so nicely this interesting clinical problem sleep disorders in menopausal women. So my task today is to summarize the treatment strategies that we can use in order to tackle those women who do develop sleep disorders at the time of menopause. So let me show you first my disclosures. I do a lot of research and consulting from companies that might have interest in drugs that are sold for menopausal treatment of menopausal disorders. So when we assess sleep disorders, as you've heard before, there's a lot of comorbidity. There's a lot of things that have different weights in terms of either causing or modulating the presence or the severity of the sleep disorders. We do need to be aware of a number of things. Every woman has a personal sleep history, so women are different. And sometimes we do incur in women that tend to worsen at the time of menopause, but they've had a previous history of sleep disorders. And of course, medical and psychiatric history is as important as all the changes that we do as gynecologists or menopause physicians do associate more with a menopausal transition. So we need to be a bit up to date with all the conditions that might have an impact on sleep. We have instruments, which we will discuss in the later slides. But we do need to more or less be aware that you have a woman, you have her problems and her history, but there's also some comorbid conditions that do impact a lot on the way she will perceive or she will experience her sleep, particularly at the time of menopause, because of the interconnection with vasomotor symptoms mostly, but also with anxiety disorders and mood disorders that tend to affect also a number of these women. So what's the pathway, the clinical assessment that we want to follow in order to try and understand what's the problem and start making a treatment plan? So first, we need to understand the type of sleep disorder. We need to understand what is the real influence of hormonal changes on sleep. This webinar is focusing on menopause. So of course, the most obvious change would be menopausal hormonal changes, but there might be others. There might be changes in thyroid hormones. There might be changes in other hormonal axes that just happen in this age range. There is aging and how aging affects the circadian rhythms of a person. Lifestyles are very often changing at this particular age. Many women do tend to either start or stop or limit, depending on their their story, physical activity or being forced to change their lifestyle because of working obligations that tend to be particularly burdensome around midlife in women because of career achievements and other issues. And of course, there's all the incidents of depression, which we do know in people who are affected by depression tend to reemerge as a vulnerable period around the time of menopause, which of course carries a number of problems with being able to rest, and particularly with interrupted sleep and being awake in the middle of the night. And also conditions which are a little bit more peculiar. Sleep apnea has been duly presented before, but also the restless leg syndrome, which is much more common than talked before, which is worsened by menopause. We will discuss that briefly later. So we don't need to achieve a diagnosis, and very often the history is the first and most important instrument. But as Professor Joffe has said, there's also some more objective ways of looking at sleep, and in some centers, we also have that in PISA, in the neurology department, you have the ability to monitor the sleep quality, the sleep duration, although this is very often done also for research purposes. But I have to say that this is a field where there's a lot of improvements and things moving on because of all the enthusiasm in the possibility to monitor personal activities throughout the day and the night because of the spread of wearable devices. So we do know that nowadays an Apple Watch or a Fitbit and all the other devices can monitor our activity and our sleep as well. So that is going certainly to be a field of development in the future. And then once we have achieve the characterization of the disturbances, then we then can think about what is the best treatment. And when we talk about menopause-related symptoms, particularly vasomotor symptoms, but mood disorders are as important. There's the hypothesis of a co-evolving condition. So you have sleep disorders, and therefore you, of course, worsen your mood. This has an impact on your mood, but on the other side, it's your mood that changes. And the fact that you have vasomotor symptoms that in a backward way also impacts your sleep quality. And as we have heard before, there's a lot of metabolic changes impact on weight gain that then can modify the quality of respiration and inducing metabolic changes that not just impact cardiovascular risk, but they also impact on the ability of sleeping well. And restless leg syndrome is also something that is heavily impacted by the hormonal changes. So what are the options? So once we have navigated a little bit to understand whether the problem with sleep has really a lot to do with menopause or a little bit less to do with menopausal changes, meaning vasomotor symptoms particularly, there's a number of interventions that have been explored and tested. And the ones that have been most extensively studied are the non-pharmacological options, which of course can be of value to many sleep disorders conditions, not just for menopause-related sleep disturbances. So cognitive behavioral therapy, there's some strategies that are specifically developed for insomnia, exercise, physical exercise, particularly high-intensity exercises, and strategies like yoga, particularly meditative yoga, have been shown to have positive impacts on insomnia. And cognitive behavioral therapy is thought to be the first-line treatment for insomnia in basically all age ranges. So this is something that we need to take into consideration, and we need to be able, as physicians, as menopause physicians, to counsel and to refer. So we need to have somebody who's worked up, who's an expert in providing these type of therapies. So CBT is a multi-component treatment. It targets both cognitive and behavioral factors that contribute to chronic insomnia. And it's not just easy counseling on when one should eat or the fact that one should avoid drinking coffee before going to night or should not go to sleep till late. It's something more complex. It requires a therapist, and it's much more deep because it involves questioning the ways that a person behaves during the day, during the night, and it's a therapy. It's a full therapy. And as you can see in the slide, there's a lot of trials that show that at least 80% of individuals can benefit from cognitive behavioral therapy, and about 40% of persons who can actually resolve their problem. Physical activity is a little bit more difficult because where the studies have concentrated more is a high-intensity physical activity. There's many reasons why this could be particularly fit to carry a benefit in terms of sleeping disorders. But we do know that physical activity needs to be adapted to the age. You cannot ask a 50-year-old person to start doing a high-intensity physical activity because that would be probably unfeasible, if not harmful. So in this family of intervention, there's also a number of types of activities that can be adapted to a midlife woman. Some of these also merge or include synergistic strategies like hypnosis, yoga, or massages that can be very often found in the gyms nowadays, at least in places where gyms are complex enough such that you have therapists and persons that can follow an integrated physical activity program by adapting it and by increasing the intensity with the degree of fitness, while the degree of fitness improves. And of course, this is also very important because of what Professor Joffe stated before, the strict relationship between sleep disorders and weight and fat gain at the time of midlife. There's a clear relationship between being fatter, having more fat, particularly visceral fat, and the number of disorders. It's not just sleep, but there's also a relationship with sleep. And we do know that this also goes through the mechanism of making the respiration rhythm and respiration physiology worse by facilitating the development of sleep apnea and making a worse, providing a worse score in the apnea hypopnea index, which is an index that measures the ability to breathe during the night. So this is very important because we do know that at midlife, as we have heard before, you have a change in body weight, you have a worsening in sleep, and you don't really know, if it's the egg or the chicken that comes first, but certainly they don't go well along in creating a circle, a vicious circle that makes everything worse, inducing fragmented sleep, night awakening, and by making sleep worse, as we have said. Now, what's the restless leg syndrome? This is a phenomenon that is quite frequent after a certain age, after 40 years of age. In men and in women, it happens, but women have it more frequently. It's calculated that it's estimated that about 5 to 10% of the population is affected. So it's not a trivial problem. It can be minor, it can be more pervasive, and therefore it becomes interfering with sleep. So the interesting thing is that there's a lot of reasons why this restless leg syndrome can emerge. Iron deficiency is a very common issue. So we do know that women at the time of the menopausal transition are very often iron deficient because of the bleeding problems that very often affect this age range. But there's also the problem of hypothyroidism, which is extremely frequent in women at this age range, and sometimes diabetes also starts to emerge. And menopause increases the symptom severity. So what is this? This is a condition where you have periodic limb movements, so your legs are moving, you have small cramps, which of course impairs sleep quality and can disrupt sleep. And it's make it both difficult to initiate sleep, but also to keep sleep ongoing, to regain sleep after a midnight awakening. So this is very important, and we do know that there's quite clear data from the sleep experts that show that there's an increased prevalence among women, particularly those women who have vasomotor symptoms during the menopausal transition, which creates a relationship between the neurophysiological changes in the brain and the hypothalamus of a woman at the time of the menopausal transition and this phenomenon. But there's also data that shows that those who start hormone therapy to address vasomotor symptoms don't really have a clear benefit in terms of reduction of restless leg syndrome. And there's a number of approaches that are considered to be of value in this condition. Some of them are, of course, quite obvious for persons who have problems with sleeping, like avoiding nicotine and caffeine, but also avoiding antidepressants or antihypertensive drugs, some hypertensive drugs in particular. Iron replacement in cases of iron deficiency is important. And between the drugs that can be prescribed for women with restless leg syndrome, there's dopaminergic agonists, but also sometimes strategies that are more associated with side effects like gabapentin or pregabalin can also be used in cases of severe restless leg syndromes. Now, I think that if we are following a webinar organized by the International Menopause Society, we are all very interested in how hot flashes, which is the paramount symptom of the menopausal transition and afterwards, impacts sleep quality. So there's a clear number of reasons why this happens. And the issue is that is hormone therapy going to be something that would improve sleep quality in women who do experience vasomotor symptoms at menopause? And then the answer, of course, is yes, and that's quite clear. And Professor Joffe has shown that in her graphs and her slides. And as she has said, it's both the estrogen and the progestin component who can improve, who could participate in improving vasomotor symptoms. And between the mechanisms that have been hypothesized as causative in this improvement in sleep quality, we have the shortening of the sleep latencies, the reduction of the restlessness, nocturnal restlessness, and the nighttime awakenings, and also decreasing the arousals in the movements, and of course also improving sleep efficiency and the phases where you reach the rapid eye movement sleep, so the most profound stages of your sleep. Now, we do know that here there's something that needs to be said, because estrogens and progesterone are not the same. They're both sexual hormones, they're both steroids, but they do have very different receptors. And within the differences is that we have between these two very important hormones is that progesterone also causes a number of things in the brain, which are due to its peculiar chemical structure. For instance, progesterone can stimulate the release of GABA in the brain, but progesterone can also be transformed through a 5-alpha reductant and a 3-alpha hydroxysteroid dehydrogenase. It can be converted to a particular steroid, which is called allopregnanolone. Now, allopregnanolone is considered to be a neurosteroid. And this is a word that indicates the fact that this is a steroid that is synthesized in the brain, and progesterone is the main precursor for this steroid. But allopregnanolone is a direct agonist for the GABA-A receptor. And again, GABA-A receptor is the receptor that is activated by benzodiazepines, which is very important for anxiolysis and for sleep induction and maintenance. So the fact that women during pregnancy tend to fall asleep is largely due to the vast amount of allopregnanolone that can be produced because of the excess in or the increase in progesterone that they have. On the other side, losing progesterone at the time of menopause is considered to be probably one of the reasons why sleep becomes worse, because of the reduction of the availability of allopregnanolone on the GABA-A receptors in the brain. And of course, this receptor is tightly linked also to mood, to the emotional state, to the affectivity, which also affect sleep quality. There's also some other approaches. Professor Joffe has noted before that some of the non-pharmacological options, that non-hormonal options that we have for the treatment of hot flashes, like SSRIs or SNRIs, are also quite effective to treat insomnia. And that is true, and that is true also in women without flashes, and that is also because in part these compounds also decrease the incidence of hot flashes, but they seem to have also effects because of their specific effects on mood. Gabapentin is also important. However, it's more difficult to be used. And also some antidepressants like escitalopram and citalopram, which have been more extensively investigated, can be tried, particularly in women with comorbid depression, because most of the studies have been done in women with sleep disorders, with or without vasomotor symptoms, but in the presence of depression or mood disorders. So, having said that, there's also a lot of use of integrators, over-the-counters, and one of the things that has been made more popular is the treatment with melatonin. Melatonin, you know all that it's a circadian hormone that is associated with night and reduction of light, and it is considered to be important in the phases of sleep induction and reducing sleep latency. And there's a lot of products that are on the market that provide particularly slow release melatonin or rapidly release melatonin to maintain or to induce sleep. And it's very debated the true effectiveness of these compounds, but of course they're used a lot in the real world as OTCs. So the recommendations, the main recommendation tend to focus on the fact that cognitive behavioral interventions and identifying comorbidities, particularly for restless leg syndrome and obstructive sleep apnea, are very important, and they have a recommended level in women with sleep disorders. Other suggested therapies, so the suggestion is a little less strong as with CBTI, is for exercise, hypnosis, hormone therapy, and progesterone, particularly micronized progesterone, and this is because, of course, that mechanism that I hinted to before, and also escitalopram, yoga, massages can also be considered. But there's other less established therapies where there's less data, so they cannot be recommended right now as main or first-line approaches. So in the end, and I'm moving towards the conclusion, so good sleep quality is absolutely important for good health and quality of life. Quality of life comes by itself. We do all know how miserable we feel when we cannot sleep, particularly at the age of 50, and I know what I'm talking about, but as I think most of you, but also for good health. So the data that Professor Joffe showed before, the relationship between sleep, metabolism, and cardiovascular disease is of paramount importance. So just a final note on saying that there might be additional strategies emerging in the future because of the possibility to use apps and wearable devices, which have been used so far mostly for monitoring sleep quality. This is a screenshot from an app that we in PISA developed a few years ago together with a consortium of companies to monitor and to promote a healthy lifestyle in midlife women undergoing menopausal changes. And one of the items that we were exploring, because the app was actually connected to wearable devices, was sleep amount and sleep quality. Now, there's a lot of, this is a screenshot that I copied yesterday from by Googling best sleep apps, and you can find now a number of apps that are over the internet that are more or less associated with wearables that provide you with a number of options to either monitor or to do things like meditation or programming or self-monitoring or self-help to promote sleep quality. And I think that in the future, these type of approaches will become more and more popular, mostly because it can be used directly by women as a self-empowerment strategy. So to conclude, menopausal sleep disorders are a broad variety of manifestation. It's not just insomnia, but also breathing disorder, movement disorders, and they're all intertwined. So they're all interconnected. Vasomotor symptoms are absolutely powerful phenomena that determine worsened sleep quality, and they also impact mood and quality of life, of course. So treatment for vasomotor symptoms needs to be taken into serious consideration, and it will impact also sleep quality. There's a number of interventions like cognitive behavioral therapy, hormone therapy, antidepressants, particularly citalopram, that have been explored as good treatment options for women at the time of the menopausal transition. Melatonin is out there. It probably requires some more solid investigation in order to set up the real efficacy. And again, optimizing quality of life and quality of sleep through mobile coaching systems is probably something that will help women in the future. So let me just take the chance to remind you that in May we will be in Florence for the European Congress on Menopause and Andropause. So I think that for this audience, this is interesting. And of course, I think that Wendy will show this later. But next year we will be in Melbourne for the 19th World Congress on Menopause. And being a board member of the IMS, I can't refrain from showing the save the date. So thank you. And I'll stop sharing my screen.
Thank you so much, Professor Somoncini. And now we're going to entertain some questions. We have about 11 questions. And actually, I have a question. Where does orexin fit in with all this? Either Dr. Joffe or Dr. Simoncini.
I'm happy to start if that would be helpful. Maybe.
Okay, thank you.
Continue. So the orexin agents, suvorexin and others, have been studied. We actually did a randomized trial showing efficacy of the dual orexin agent, suvorexin, for menopause-related, hot flash-related insomnia. So it was effective. It's been studied for insomnia in general and is approved, and we showed its efficacy in this particular population as well. We also showed that the hot flashes were improved with it, of course, during the night, because people either they're not sleeping through them or they actually had some sort of thermoregulatory effect, because orexin, affects arousal and alertness. So.
And we didn't talk at all about the Z drugs.
Isn't that interesting? I mean, really, so these are the zolpidem and the family partial GABA agonists, and they are effective and they do work. Now they have their challenges in terms of continued use. So we tend to try and minimize their use and use them more short term, but certainly they're effective. You're not treating. So if you're talking about insomnia and you think it's related to hot flashes, a significant insomnia, that they're a major hot flash contributor, I always start by trying to treat the hot flashes, the nocturnal hot flashes. But if you think it's insomnia in the absence of hot flashes or unrelated to, they're very effective, certainly.
Okay, Dr. Simoncini, you agree or?
Yeah, absolutely. I
Okay.
wouldn't be able to add anything more. Yeah.
Okay, so easy question. Does sleep fragmentation affect equally men and women around midlife?
Well, my personal experience is yes, of course. It's always a bad experience. Saying that from an obstetrician's point of view, when you tend to go to bed and re-sleep is not a good experience. This is not of course, a research answer, but I think it's an easy answer. Yes, I don't think there's any difference.
But I think, Dr. Joffe, you actually have data about men and women being
Yeah.
affected more.
Right. I think the point that I agree with Dr. Simoncini's comment that you have age-related changes
Yeah,
for men and women, and that does include a sleep fragmentation and interruption, and also a shifting to earlier sleep. In addition, both men and women have health reasons why they might be waking up in the middle of the night, and they may be, urination or other prompts, or GI, gastrointestinal distress, environmental factors. So men and women are exposed to health related and environmental factors that contribute. The women have this additional factor of hot flashes, which is where the focus of the discussions were. We've done our experimentation protocols in men and in women. We don't manipulate the hormones in men. We haven't so far. And we're looking at whether the cardiometabolic changes are the same in men and women. So I don't have the answer to that yet, but it's possible that both men and women have it, but the health outcomes might be a little bit different.
okay. What is your opinion about the new NK3R antagonists and their effects on vasomotor symptoms and sleep?
Do you want me to start? I think
Yes,
it's
yeah.
I mean, I think it's a very interesting challenge that we have had to understand whether so these will be drugs that have I wouldn't say a totally selective mode of action, but it would certainly dissect vasomotor symptoms from other disorders that we have at the time of menopause. So I think it's not just interesting, and of course, in the setting of sleep disturbances at the time of menopause. That would be particularly interesting in those women who are really experiencing their disturbances because they develop vasomotor symptoms. But I am convinced that since they work in the end by modulating a number of neurotransmitters within the hypothalamus, that we might discover that there's a broader effect. I am not aware of any solid data right now on sleep disorders, but this is certainly one of the obvious areas where we are curious to see the effect.
Yeah, I think that I was involved with some of the evaluation of the data from the companies, and I think they do have sleep data, but we'll have to wait for the publications. Do you use progesterone even in patients without a uterus to improve sleep in menopause? Dr. Simoncini?
Not on a usual basis, but sometimes if I have patients that do have a profound sleep disturbance, micronized progesterone can be something that adds up on estrogen. So if that patient has not a uterus, you wouldn't be needing any progesterone overall. But if you have this type of disturbance, why not? So it's not something that is necessarily going to hurt. So I've done it on a selected number of patients.
And why couldn't you use pregnenolone as an alternative for progesterone?
Why should I? It's so easier to use micronized progesterone. So I think it would be just more difficult to also find it on in the pharmacies.
Okay. What about synthetic progestins? There's a researcher whose area of expertise is allopregnanolone, and Dr. Bronson, and she says, this is my research area, but there is please distinguish between progesterone and the critical distinction.
Yeah, you want me to address that?
Yeah.
So this is the major difference between synthetic progestins. Any synthetic progestin cannot be converted to allopregnanolone. So in terms of that central neurosteroid production, any progestin is perfect to protect the uterus, but doesn't do this type of effect. Which is sometimes a side effect of micronized progesterone. So it's it really depends on what you want to achieve. But the only compound that can be converted to allopregnanolone is progesterone itself. Even dihydrogesterone, which is the stereoisomer, cannot be converted to to allopregnanolone. So this is a chemical difference that distinguishes the neuroactive effects of progesterone from those of any other synthetic progestin.
What Dr. Naftalin says, what is the role of sleep testing? For example, RLS is often underdiagnosed. So even if, would you replace women first? And if they don't respond, do sleep testing, or should you do sleep testing right at the beginning? Like sleep lab, etc.
I'm happy to comment there. I just want to add one comment about the progesterone. So just like Dr. Simoncini said, progesterones can be used because of their beneficial effect on sleep. And just a reminder that for women who can't take estrogen, but can take progesterone, progesterone alone is an effective treatment for vasomotor symptoms. So for somebody as an alternative to estrogen, progesterone alone can improve hot flashes and associated sleep disturbance. So just a comment, and different progesterones, of course, the natural micronized being optimal. The comment about the question about sleep studies. So restless leg syndrome, which is a sleep onset problem, falling asleep because of this urge to move the legs that is relieved just temporarily by movement, is often diagnosed clinically. You can diagnose it in a sleep lab because we do look at muscle movement with leg monitoring and so forth. But it is diagnosed clinically. So it can be, if there's a presumptive diagnosis of restless leg syndrome, it can be treated. And as Dr. Simoncini said, usually with dopaminergic agents. So that doesn't necessarily need a sleep lab study. If the concern is more that there's the periodic leg movement problem, which is the middle of the night sleep problem, kicking, bed being very messy, bed partner information can be very helpful there. And similarly, often that is not necessarily diagnosed with a sleep lab study because it's expensive and cumbersome, and you can get more bed partner intervention information. And but when it starts to become confusing, does somebody have vasomotor symptom related sleep disturbance that's awakening them in the middle of the night, or this kicking periodic leg movements, which almost always occurs in the context of onset problems related to restless legs. A sleep lab study can help distinguish it, of course, because you can quantify the number of leg movements in the middle of the night that is linked with an awakening, which is the key sort of metric, the index.
Okay, there's a question. Why is quetiapine not recommended? Kvetiapin. Is anybody familiar with that?
I wondered if that was quetiapine.
Oh, okay, quetiapine.
Which Dr.
Yeah.
did mention, but I'm not sure if it's
it probably is
I'm not familiar.
Yeah. So I think there was on your slide, Professor Simoncini, but you sort of glossed over it. Why don't you use quetiapine?
Well, I'm not really an expert on quetiapine, so this is those. So let me skip this. So I wouldn't be able to give you a right guess.
Hey, Dean, I'm sure has experience with it.
Oh, yes. I mean, I agree with the recommendation that it can be used. Its primary use is for as an antipsychotic and as indication as an antipsychotic and as an antidepressant in people with bipolar disorder. However, the vast majority of its use is at low dose at bedtime for sleep onset, sleep maintenance, and it's very effective. And that's of course used off-label. So it's a good alternative to consider.
What melatonin dose should we use?
I'm happy to start if you want.
Okay.
Yeah. So melatonin, oftentimes you see 1, 3, 5, even 10 milligram pills. Usually 1 to 3 milligrams is sufficient for certain kinds of sleep disorders. So now we're talking about like a jet lag syndrome or a time change syndrome. melatonin 1 to 3 milligrams is usually sufficient. For certain kinds of severe sleep disorders, if we use it up to 10 milligrams, it can cause headaches. So it's not, side effect free. I think the main thing is that people should take it when they have a more of a jet lag sleep onset problem, take it an hour before bedtime and minimize light exposure. That's so critical. The whole idea of melatonin is that it's naturally increased when there's a reduction in light. So staying in front of a screen or bright lights in your home reverses any effect that their natural or exogenously administered melatonin would have.
Could someone comment on FSH's effect on sleep?
I don't think we know very much about it. I mean, I think it has been, it has, in the setting of the hormonal changes that are linked with the sleep interruption, hypoestrogenism and a higher FSH is associated. What mechanistically contributes is harder to say with FSH, but we did find that it was associated, as you would expect, hypoestrogenism and higher FSH obviously going hand in hand.
Yeah, if I can add on that, so it's we don't really know on this particular area, but there have been quite some nice studies in animals in the past 5, 6 years showing that FSH receptors are involved with thermogenesis and with the accumulation of fat. So having more FSH, like you have after menopause, could actually drive increased fat accumulation in animals at least. So it's one of those fascinating areas that has been underexplored. So whether gonadotrophins have receptors outside the ovaries, it seems so, and whether these are relevant. So in other words, whether they do, the fact that you have increased FSH levels or LH levels does make any difference. Also, those data on fat accumulation that Professor Joffe showed from the SWAN study. Of course, one of the things that somebody argues is that fat accumulation before the age of estrogen cessation might actually in part be attributed to the fact that you have increased FSH levels in that age range. We don't know, so it's just very hypothetical, but there is some animal data to show that, to suggest that this might be interesting.
Good area for future research. I have a practical question. If you had a patient in the perimenopause who was on oral contraceptives and still having sleep disruption, could you add micronized progesterone? She's on a synthetic progestin.
Well, you can do anything you want in life, but if she's in perimenopausal and she's using an OC with estrogen, I think it's very difficult that she would be experiencing hot flashes. So I would probably consider strategies that do not specifically target hormonal changes. So I would probably go on to more behavioral interventions like CBT or exercise, something that I wouldn't expect having more progesterone would help. But of course, this could be something that could be tried. I don't see any major reason why this could be absolutely forbidden. So I wouldn't consider that as a first line intervention.
Does anybody have a practical self-help for CBT for insomnia? Any recommendations?
There are online resources that there are apps. There's 2 that are used widely, one called Shut Eye and one called Sleepio. And I'm sure there are many others, but so it's hard to get a CPTI trained therapist often. And so these resources, they're personalized. So you get feedback, you enter your information about your sleep patterns and behavior, you get feedback that's personalized to you. So I believe they have a cost, there's a charge, but that's a way to get access to those behavioral interventions without a therapist specifically.
Okay, thank you. Is it wrong to put women on sleeping tablets and continue forever?
I would say so, yes. If that's the only intervention.
You would say, yes, you can continue? Is that what you
No,
mean?
I would say, yes,
Or-
it is wrong. So
Yes,
yes,
it is
we
wrong.
didn't,
Right,
yes.
right. Yeah, yeah. I mean, there are people who need it, you know, I think it's not our first line approach, I agree. I mean, you say sleeping tablets, I think we're talking about the Z drugs and benzodiazepines. You know, there are people who do need them, but it's not the first line approach. And oftentimes they can be valuable as what we call like a rescue strategy, meaning there's a first line approach, a behavioral approach, or perhaps a medication approach. And for somebody who really has severe chronic insomnia, they have a rescue that they know is effective, and it can be one of those agents. But there are some people, I mean, it's a chronic severe disorder for some people and they just need it. But your average person without a chronic severe insomnia, that's not the typical approach.
Okay, someone writes, slightly off topic, but why does progesterone cause a profound decrease in mood in some women? This can negatively impact sleep. And okay, just comment on that. Yeah.
I think that's really interesting. I mean, as a psychiatrist, you know, I've certainly seen people with this idiosyncratic reaction. We actually showed in some studies that progesterone did not have an adverse effect in the vast majority of women who were taking it in combination with estrogen. So I wouldn't avoid progesterone in people where there's a mood concern, but it is true that this can happen rarely. And I've also found that, you know, swapping amongst the different synthetic and natural approaches between them, you know, sometimes people have tolerate one better than the other, in the same way that oral contraceptive agents with the different synthetic progestins can have an adverse mood effect, rarely, but swapping amongst the different progestins, you can find one usually that does not have that adverse effect.
Is there any association between specific types of vascular atherosclerosis and sleep disorders and cardiovascular disease?
Sorry, the question is about
atherosclerosis, sleep disorders.
Yeah, so all of these, there are a number of the studies which is mostly with the short sleep time. Some are experimental, where we bring people in the lab and give them only 4 hours of sleep. You know, you do see these effects on lipids and other risk factors for cardiovascular disease. And we're looking at that now in the sleep interruption paradigm that I mentioned as well. So, you know, this question of why is sleep problems, whether it's short sleep or interrupted sleep or other patterns related to cardiometabolic risk, that may be because of these typical risk factors for atherosclerotic disease.
Any information on CBD oil and sleep quality? Okay, I think good studies need to be done there, but I don't think so far. I know a lot of people take it for that reason. And someone wants to know, is there any special throat exercise for prevention of relaxation of muscles during sleep time?
That's interesting. So I don't know about relaxation. I think the main thing is avoiding alcohol, reducing weight. So obviously any abdominal pressures, weight gain that leads to more thoracic pressure. So so because of the compression on the upper airway. So alcohol and avoiding benzodiazepines are really key, but I'm not sure about the exercises specifically, and sleeping more with the head up a bit more can be helpful for that reason.
Right. We haven't talked at all about reflux and its effects on sleep.
Yeah.
But I think that's can be a significant issue for many people. Someone wants to know, do you advise to take oral progesterone with food or 2 to 3 hours after food at bedtime?
I did suggest taking it before going to bed. So later than, but there's no difference in terms of absorption, but it's just more effective if you want to achieve a more profound effect during the night.
Why is prolonged release melatonin recommended over immediate release?
Good question. I mean, you know, melatonin is really about sleep onset, but of course, you're now talking about light exposure and different circadian, people have different circadian phases, early, late. So if somebody needs for more sustained sleep, you know, that's why you would potentially recommend more of a long acting, but it's usually for sleep onset.
And similarly, is there preference to taking hormone therapy transdermally or orally or vaginal progesterone? Does it make a difference?
Well, it would make a difference if you want to use progesterone to facilitate sleep, because we do know that vaginal progesterone is associated with much less sleepiness or drowsiness. So that's how we do it when we want to avoid that effect. So, and progesterone is not absorbable through the skin, at least with the pharmacological preparations that we have on the market. So you can also you can only use it orally. In terms of estrogen effects, I don't think there's any evidence that transdermal or oral estrogens have any difference in terms of sleep effects. In terms of vasomotor symptoms, they're equally effective. It depends on the dose, and so I don't think there's any evidence that one way is that one route of administration is better.
Okay, I think we covered all the questions, and I think it's wonderful to meld North America with Europe and get answers which are pretty consistent across the board. So I thank you so much for your participation today, Professor Joffe and Professor Sommaccini, and all our participants around the world. And I'd remind everybody about our meeting in Melbourne in 2024, October 19th to 22nd. So thank you very much again for participating today. Bye-bye.
Thank you.
Thank you.
Thanks a lot.
Bye-bye.
Bye.
Bye. Great.